Hi, future nurses. Welcome to one-on-ones NCLEX teaching on the myocardial infarction. So let's get started. So myocardial infarction, it's pretty much a very exciting time if this happens. It's nerve-wracking, and the patient and the family are very concerned, and nurses get a shot of adrenaline when they realize this is happening. So let's find out what we need to know and what we need to do for our patients as they move through the process. So what to look for and what to do. So we're going to talk about pathophysiology and the risk. We're going to define what happens to the body, and that's essentially what pathophysiology is. We're going to talk about the risk factors, what puts a person at risk for an MI. Then we're going to talk about diagnostic labs and tests that they run on a patient that they think has had a myocardial infarction. And then signs and symptoms, what do we assess for? Next, we're going to talk about complications and treatment of the acute stage, and then treatment following the acute, and then cardiac rehab. That's a lot, just saying. So a myocardial infarction is when the heart tissue or the myocardial tissue has an abrupt interruption in the blood flow and is deprived of oxygen. It is defined as death of the cells in the myocardium due to hypoxemia. So pathophysiology, what does this condition do to my patient? So the first thing we have to understand is ischemia can lead to death or necrosis of the heart if the blood flow is not restored. This condition of an infarction occurs over time. It's not a 1 minute event, it takes time. It happens over a prolonged ischemia, 20 to 45 minutes. The physical changes does not occur in the heart for 6 hours. And then that infarcted area will become blue and swollen. 48 hours later, the infarcted area turns gray with yellow streaks. That's because the neutrophils have all run in to help clean the site up. 8 to 10 days later, now we have granulation tissue starting to form. And over the next 2 to 3 months, the area develops into a scar, and that permanently affects the size and the shape of the ventricle and the heart itself. So the damaged cells cause a decrease in the myocardial contractility, resulting in a decreased stroke volume and a decreased cardiac output. Remembering that the decreased cardiac output usually is what's ejected from the left ventricle in a minute, which is usually 4 to 8 liters. That leads to a case of hypotension and a decreased peripheral perfusion. So it's not just the heart that's being affected by this heart attack or the myocardial infarction, it's the whole body because it's not getting what it needs. Now, the location of the MI depends on what artery or what area of the heart has been occluded. So if there's an obstruction in the left anterior descending artery, so left anterior descending artery is this one here. So if we have one there, it is the anterior wall or septal MI, or both. An obstruction in the circumflex artery. Let's see if we can find that. Okay, so here's the left circumflex artery. So if there is an obstruction there, it is a posterior wall MI or a lateral wall MI. And then if there's an obstruction in the right coronary artery, here's the right coronary artery, it results in an inferior wall MI. So risk, who's at risk for this and what makes them at risk? So we have atherosclerosis, it's coronary artery disease, it's elevated cholesterol. This is the reason that they really monitor cholesterol levels, because this puts a patient at risk for a myocardial infarction. Smoking and having hypertension and obesity are three others that put them at risk. And then physical inactivity or an impaired glucose tolerance or stress. So the diagnostic labs that we're going to look at with these patients, when are they drawn and what tests are done? So troponin, it rises within 3 hours and remains elevated for 7 to 10 days. And troponin is the first one you're going to see drawn in the ER, because they can monitor it over time to see if it increases. If it does, then it's likely an MI. The next thing they check is the total CK level. It rises within 6 hours after onset of chest pain and peaks in 18 hours. The CK-MB isoenzyme has a peak elevation in 18 hours after chest pain and returns to normal 48 to 72 hours after. Myoglobulin rises in 2 hours after cell death, and it has a rapid decline in the 7 hours after that. The WBC count elevates on the second day, and it stays that way for a week. The electrocardiogram can show an ST segment elevation or a wave inversion. In the cardiac cath, this actually goes into the heart, and we're looking to see where the occlusion is, finds that occlusion, and it uses either a stent or a balloon to open that area up to give the heart more blood supply. The exercise tolerance test or stress test is done following the acute stage, and it IDs who may need more invasive therapy. And then thallium scan assesses for ischemia or necrotic tissue. I'm planning on making future videos that will address each of these and what they show. So symptoms, what should I look for with a client that has this condition? So first one is pain. They may be experiencing a crushing substernal pain. Most patients are grabbing their chest. Typically, the pain may radiate to the jaw, to the back, to the left arm or shoulder. There's a tightness, a crushing feeling lasting 15 to 30 minutes, and it's not always the same with females, so don't expect the same answers from them. Pain is not relieved by the nitro, but it is relieved by opioids. And the duration of the pain is important in distinguishing between an MI and angina pectoralis. So remember, an MI, it's sustained time period, 15 to 20 minutes. Sudden onset of pain, usually not associated with activity. They may be awakened in the middle of the night. Tachycardia related to the pain and increased need for tissue, for the tissue to get oxygen. So ECG changes, you can have a depressed or elevated ST segment, an inverted T wave, or a formation of a Q wave. Other symptoms that you could have would be nausea, vomiting, diaphoresis, dyspnea, tachycardia, change in level of consciousness, elevated cardiac markers, which we already talked about, an elevated temp, and leukocytosis. So the nursing assessment, you're going to need to get the pain as far as the location, the duration, the radiation, and the quality, and any associated symptomology that goes with that. Vitals, heart sounds, get the cardiac rhythm, look at nonverbal cues of discomfort. Then you're going to be looking at diagnostic tests, the CPK with isoenzymes, the troponin level, the 12-lead EKG, the angiogram, the echocardiogram, the stress test, the MUGA scan, ABGs, labs, the electrolytes, the CVC, and of course, a pulse ox for O2 sat. What are the complications? What condition is worsening of an MI? It would be dysrhythmia. If they get heart failure, pulmonary edema, cardiogenic shock, thrombophlebitis, pericarditis, mitral valve insufficiency, post-infarction angina, ventricular rupture, or Dressler's syndrome, a combination of pericarditis, pericardial infusion, and pleural effusion. These complications, I will talk about them in future videos. So treatment of acute stage. The initial steps is to have the client describe their discomfort, give them O2, and institute those pain relief measures, morphine and nitro as prescribed. Pain relief increases the oxygen supply to the myocardial tissue, and administer morphine as a priority in managing the patient's pain. Assess the vital signs and the cardiovascular status, and maintain that cardiac monitoring. Assess the respiratory rate and the breath sounds for signs of heart failure. Remember, heart failure is when the heart's not pumping effectively and it's not getting the blood to circulate. So you're going to have buildup of fluid either in the peripheral extremities and or the lungs. Ensure bed rest and place the client in semi-Fowler's position to enhance comfort and tissue oxygenation. Establish an IV access, get a 12-lead ECG, monitor those lab values that we've already talked about, and monitor the cardiac for dysrhythmias. So treatment is you give them the thrombolytics if they've been brought to the ER within the first 6 hours. Remember, it can't be done after that. Or they're having a cardiac cath be done. You're going to assess their distal peripheral pulses and the skin temperature. You're going to monitor the blood pressure closely, especially when we're giving beta blockers and channel calcium blockers. If the systolic is lower than 100 millimeters of mercury or 25 lower than the previous reading, lower the head of the bed and get a hold of the doc. You're going to administer beta blockers to slow the heart and increase that myocardial infusion. You're going to monitor for major side effects of the meds, the hypertension, the bradycardia, the bleeding, the constipation and depression, and provide reassurance both to the client and the family. So following the acute, you're still going to maintain them on bed rest as prescribed, but we're going to slowly get them up. So if they're a male patient, allow them to stand to void or have the lady use the bedside commode. Provide range of motion exercises to prevent the thrombus formation and to help maintain their muscle strength. Progress to dangling their legs over the side of the bed or out in the chair for 30 minutes, 3 times a day. You're going to monitor for those complications that we just talked about. You're going to administer angiotensin converting enzyme inhibitors, or ACE, and the ARBs, the calcium channel blockers, the aspirin, and then the cholesterol lowering drugs. You're going to encourage the client to verbalize feelings regarding the MI. And then cardiac rehab. What happens here is we assist the client to get back to the vital and productive life within the limits of the heart disease. It covers diet and exercise, We're monitoring exercise in the rehab, and then we slowly release them to do it outside. 35% decrease the chance of dying after an MI or cardiac bypass surgery after 5 years if they do cardiac rehab. 20 to 25% reduction in mortality when a client does cardiac rehab. So it's 35% decrease in the chance of dying. Okay. And then 20 to 25 if they do the cardiac rehab. So NCLEX question. A nursing student is doing an assessment of her assigned client who was admitted with the diagnosis of COPD exacerbation. She notes that he's complaining of left arm and jaw pain. He appears a bit short of breath and is complaining of just not feeling well. Which plan below indicates that the student understands the instruction she's received about a myocardial? We're going to ignore the need for further instruction at the moment. So I'm going to give you a minute. The patient is anybody. They have a diagnosis of COPD, but now they're complaining of left arm and jaw pain, which is an indication of an MI. They're short of breath, again, indication of an MI, and complaining of just not feeling well, again, signs of an MI. So which of these four would you do for a patient that is having an MI if you are a nursing student? You have to bring that in as to who's doing the care. All right, answers. I've highlighted the most important things, which I just went through. And of course, it's do vital signs and alert the nurse. I hope this has helped you. If you have any questions, you can email me here or you can call us here at the office. The area code's 317-288-7241. Thank you. Have a good day.